Hi, this is Rich Branson, Editor-in-Chief of Respiratory Care. Joining me today is Dr. B. Ben Khallouq. Dr. Khallouq is going to talk to us about her editorial in the journal Respiratory Care called Expanding Medical Findings to Include an Explanation of Social Determinants of Health. Her editorial is based on a paper that was published from University of California, San Diego by Dr. Burton and colleagues that looks at the outcomes of patients with acute respiratory failure in rural and urban hospitals, and the term urbanicity comes up. And I think it'd be surprising to a lot of us is that patients in the big teaching hospitals often do worse than the smaller hospitals, and even if it's a non-academic teaching center. And it has to do with where those patients come from and the experiences those patients have in the medical system. So in the editorial, one of the most important concepts, I think, is this idea of social determinants of health. B, if you don't mind if I call you that,
Yeah.
Give us a little discussion about what are the social determinants of health.
So I think when we think about social determinants of health, for me personally, first we have to establish that those determinants of health are not the same for everybody. So it is really the social, right? Where we live, where we play, where we work, and all that creates a social environment. So I like to use myself as an example all the time. So I'm a first generation immigrant, right? And that has a lot of meaning for people, because we all imagine what an immigrant looks like. But I'm unique in that my parents were documented immigrants for most of my life, so they were not undocumented immigrants. So that experience already looks different. And so to contextualize that, what makes my social determinants of health, the immigrant experience becomes part of that. But that's not the same for another person. So those social determinants of health for you, for example, might be different than those are for me. And so when I think of social determinants of health, it is all those things where we work, live, play, as the slogan says, but it's very unique to you. So it's thinking about the social, but it's also, to me, thinking about the individual, thinking about how you as an individual interacted with that social environment and what you were able to tap into that environment for health purposes, and what you were not able to tap into for purposes of not being healthy. Yeah.
I think this paper is going to be, I think, surprising for some people, because a bunch of us probably think working in a urban hospital, often in the past called an indigent care hospital, or the hospital where people come who don't have health insurance, is that we have many programs, experts, worldwide experts. Why are our outcomes not better? I think off the cuff, if you just ask people, they'd say, oh, patients at my university do much better than patients at the hospital in the community. And it turns out from this analysis, now this is a big data project, tens of thousands of patients, they don't do as well. And that's where the concept of health inequities come in. So give us an idea of what is it, some of the health inequities that affects this individual who comes to my hospital, but probably doesn't go to the community hospital in the suburbs. Why are they at a disadvantage?
So again, so to kind of on average, your patient, it's gonna come from probably an impoverished neighborhood, because teaching hospitals are situated within those neighborhoods, right? And they're likely, and I say come from an impoverished neighborhood, which means they're also impoverished or situated socially in other ways that marginalizes this type of patient. Less access to education, less access to healthy foods, less access to leisure. For example, urban communities per se don't necessarily are oftentimes gentrified. And so you'll have no spaces for leisure. So in my local neighborhood, I may be able to go to a park and truly enjoy the park and enjoy nature, which has been associated with good health. But your average patient's not going to have access to that. And so in particular, I like to use the phrase the other side of the tracks oftentimes, because it means something to a lot of us as Americans, right? And our teaching hospitals are oftentimes situated on the other side of the tracks, where we actually have built communities that are already impoverished, and then the hospital becomes part of that community and never truly serves the needs of the community, if you would. So it's not just about the hospital being situated in a particular geographical location, but it's more about what did that geographical location look like prior to the hospital coming to be in place? And what are some of the systemic things that keep these geographical spaces, quote unquote, being urban, quote unquote, being the other side of the tracks, or being the north side or the south side? Those are things that are meaningful to all of us that live in America, right? And so they take meaning. And because they take meaning, when the next Whole Foods is thinking about building a store, they don't necessarily look at those neighborhoods to build.
It's interesting because this hospital that I have worked at for 40 years, has been in the same spot for a very long time, 100 years more. And my father-in-law and his 7 brothers all grew up literally 2 blocks from here, and what they used to refer to as the Catholic ghetto, because 7 boys all lived together. And my wife was only born about 3 blocks from here when she was a little girl. But yeah, clearly university hospitals on the whole tend to be in areas where, not as many people are going to live and don't have access to that. And that was, so again, I'm just, from my understanding, we're talking about pollution, people who live in the cities, both from cars and manufacturing. Well, the manufacturing part's starting to disappear to some extent. The history of chemicals and trash dumps, the lack of access to food. These are all these inequities. And I want to ask you about a word that causes people some discomfort, this idea of structural racism, which I think people think, what I worry is that people think you're accusing them of something, but that's not it. So give us a good definition of structural racism and how important it is to the health of people who attend these urban hospitals.
I love this question. So structural racism, I think I should, it's exactly what it sounds like, right? I hate to give an academic explanation. There's a structure. So I think of your home or your hospital or your community. And within that structure, there's racism. It's in it, it's within it, it's part of it. And I think that is, to me, what structural racism means, right? We can get into all the intricacies of how it manifests and what it becomes, but I think, it makes all of us shriek, right? Because none of us want to be racist, or none of us want to be known as a racist person. But the very fact that we exist within these structures, the very fact that I can exist within a certain social space makes me racist, right? And so that's kind of one of the tenets of structural racism, is that we all are. But I think to kind of talk about it and unpack what all that means is really to think about it. Okay, so here's this institution. We're talking about the institution of medicine right now. And within that institution of medicine, there's a history of racism, and there's a history of oppression, and there's a history of marginalization. There's a history of health inequities. And part of that history is reproduced. And so it stays within the structure, right? So you and I may join a structure tomorrow for the very first time, but we become part of that social space. Does that make sense? Yeah.
Yeah. I think, people are impacted by those words, and you and I have had the discussions before. The goal is not to get people to say, oh yeah, I'm part of the problem. The goal is to get people to say, hey, there's a problem here, and we need to put in plans to help people who've been marginalized and are afraid of healthcare because they're afraid of doctors and they're afraid of maltreatment. Here at Cincinnati, I'm sure you're aware of the radiation experiments back in the 70s, where mostly Black patients with virtually terminal cancer, were given an opportunity to get radiation, and The real goal was to determine how much radiation those patients could tolerate. And we have a brick plaque out back with all their names on it to remind people of it. And everybody who parks has to walk by it on the way into the hospital. I don't know how many of them know what it means, but this is real. And one of my colleagues for a very long time is a Black trauma surgeon, critical care physician, and his wife is from Alabama. And she would always remind us that when they were kids, they would hear about night doctors who would steal bodies, which is probably, for dissection, which was done in the early 1900s. And again, I wasn't there for part of that, and nobody I know was, but that doesn't change the fact that it happened. And over the course of time, those stories get told and sent down to people. And people, the vaccine now, there are some people who won't get vaccinated because they don't really trust the medical system. And that alone means this is a solution or a problem that we really need to solve.
Right. And so yes, we need to solve it. And the question becomes like, how, right? How do we solve it? It takes, I think accepting that it's going to take a while is good. It's good for you. It's good for me, right? I love your example about walking through that wall, right? So I wonder, sometimes we do this ritualistic, right? We engage in these ritualistic practices. And so I like to think of like that example of the wall, walking through and remembering, right? That is part of like what we did as a hospital, but also accepting it, right? Being part of being like, well, we did this. And I think that's part of the healing process that not me or you or our significant others or our family needs to heal through the process. But I think as a country, we have to heal through that process. It sounds so sometimes very pop psychology, right? Like, let's heal the soul, but it really is. I think it's about healing, right? It's about healing the wounds of the past and asking ourselves, what can I do within the space that I'm at? Because we all have different positions and we all have different impact. What can I do to change this? Or what can I do to start the dialogue? Or no longer become part of this?
That would be my last question for you. So the majority of the readers of respiratory care are respiratory therapists, physicians, some nurses, some outside the country, but the majority of them are, staff respiratory therapists who come to work every day in an intensive care unit or in a pulmonary rehab clinic, or maybe they see patients at the home on home oxygen therapy, giving aerosol treatments, providing mechanical ventilation. They come in and they usually have a 12-hour shift to work, and they're in the ICU. Look at me and pretend like you're looking at all of them and say, here are 3 steps that you can start to help you, move through this point where we can, participate in the healing.
So 3 points. I think the number one, again, very pump psychology, is like you have to be present, right? And you have to be medicine is changing so fast and so rapidly. And with our institution of medicine changing that fast, you have to be purposeful. If you are interfacing with a patient, you have to pause, like just pause, right? Take it all in, absorb who they are as a person, and then situate, I guess, all the assumptions, all the things that we think of that person within a social context. And so I'll give you an example. I see you and I might be like, oh, doctor, some white hair going on, older than me, right? White coat. And I assume so much already. And that's what I mean by being present, right? You're facing a patient, look at them and really take the time. I used to have a mentor that used to tell me that if I walked out of a conversation and I didn't know what color the other person's eyes were, then I had not been present enough, right? And so I think that's important for everybody that interfaces with a patient, right? So, and I think that is not going to resolve racism, but it's going to humanize the interaction. And I think it could do a lot for our interactions. If I see you, right? And so being able to lock those eyes with a person and acknowledging that it's another human being regardless, right? So that's one thing I think. The second thing is treat the patient in consideration of all those things that you might have imagined and that are missing, right? And so what I mean by that is, I oftentimes see like my colleagues, right, face a patient and they make assumptions about a patient, right? A smoker, well, they're smoking. Well, yeah, but we have to go beyond that. Like, why is this person smoking? And instead of making that judgment situated of like why people smoke, I mean, for a lot of people, that's a stress relief, it's an anxiety, right? It's an addiction that can be resolved. It's a coping mechanism. So being able to situate the person within the social, and that's what I mean, right? And then the third thing is be reflective. When you walk out of that room or that interaction with the patient, acknowledge if you felt uncomfortable about something that was exchanged, acknowledge if you made assumptions about the person, and then ask yourself why, right? And again, I give myself as an example because I can only speak from my standpoint, but to get to work, I drive through downtown Orlando. And I count anywhere between 10 to 12 homeless people on my drive-in. Orlando's rather warm, right? Every once in a while it gets cold. But for me, almost immediately, as soon as I get off the highway and into downtown and I see the first homeless person, I make sure my doors are locked. And I have had to ask myself, why do I do that? Like, why do I feel unsafe? So I equate homelessness with unsafe. And so I'm able to use myself as an example, not because I think we all do that. And I think having been engaged in work of health inequality and inequalities in general, I've had to ask myself, what is it that I do that contributes to that at a very personal level, you know? And then if you're in a position of power, you know, bring it up. I mean, take it up to somebody that may be able to, restructure the system. Yeah.
Okay, B, thank you. This was great. I appreciate your time and appreciate the effort you put in on the editorial, along with Dr. Shellhammer. And I'm sure the readers will enjoy this and hopefully they'll enjoy this conversation on YouTube.
You're welcome.
Thank you.
Thanks.